So good evening, everyone. Thank you so much for joining us today on the 31st. I know it is very difficult for all of you back home, and you have still obliged, especially the speakers. Thank you so much. This is a first of its kind Mastery of Surgery meeting. May I invite Dr. Sharad sir to welcome all of you. Sharad sir, please.
Thank you, Ziba. Good evening, everyone. And it's a great honor as the president of the Indian Association of Surgical Oncology to welcome you all to today's webinar, the IASO Masterclasses. This time it's a bit different. This time we are going to go into the intricate part of the surgeries which we will be discussing. Surgery, as you all know, is the place, is our profession, and we earn our bread, we earn our butter through surgeries. Though we most of the time discuss only about academics, which was about theoretical part. So we are going to now discuss about the practical aspects of our profession, that is the surgical oncology. In a real sense, that is how we incise, how we suture, and how we ligate, everything of that sort. Thank you, Ziba, for all the preparation, this interesting concept, and thank you, Dr. I don't see Dr. Rao there. Thank you, Dr. Rao and Dr. Srijan also for working hard to bring this session into place. Over to you, Ziba, and I welcome Dr. Subaya, Dr. Prathamesh, and Dr. Venkatesh for the session also. So, Ziba, I think we can start.
Yes, sir. One moment. I'm trying to connect to TS Rao, sir, and just give me maybe 2-3 more minutes and we'll start.
Hi, Sabita.
Hi.
You are in Bombay or Mauritius?
No, I'm in Maldives.
Maldives. Good. Enjoy.
Ziba?
Yes, we're good to go. So,
Ziba, I think Dr. De Cruz and Dr. Toprani are in the attendee list. They are very prominent
past
people
president.
in oncology.
No, past presidents, I think.
Dr. De Cruz, unfortunately, is not the past president, but he is a very prominent person. So, can we take him as a panelist inside?
Yeah. I'm doing that. I'll do that. Yeah. Toprani, sir, I've put as
Toprani,
panelist.
sir, and De Cruz, both you can upgrade to panelist.
Yes.
I think Asutosh, Manisha, and Sabita and Narendra, everybody has joined. Venkatachala. I think.
Yeah.
Welcome, Toprani, sir.
So I have included both Toprani sir and Anil De Cruz sir to panelists, and they are more than welcome to give the valuable opinion. With this, we will start off with the first presenter. He requires no introduction. He will be covering 20 minutes of this session. Dr. Prathamesh sir, he will cover the basic radiological features of laryngeal cancers and the treatment planning, which is really important and not very well covered in most of our academics. Over to you, sir.
Thank you. You'll have to allow me to share screen. Good evening, everybody, and thank you for the opportunity to present to you the guidelines in the management of laryngeal cancer. So what we will focus today in the next 20 minutes is to discuss about what are the basics in embryology and in the clinical manifestation of the diseases and how we are going to evaluate these patients. So I'll talk about embryology, the spaces and the spread, how we evaluate these cancers, stage them, and what are the treatment options. So when you look at early laryngeal cancer, let's focus on 4 aspects: the extent of spread, the cord mobility, the framework, and the function. So in an early laryngeal cancer, the tumor is limited to the lumen. The cords are mobile, the framework is normal, and the patient has a normal laryngeal function. In an intermediate laryngeal cancer, the tumors now tend to reach the laryngeal spaces. The cord mobility may be impaired, the framework is normal, and the function is also compromised. And then when we look at the advanced cancers, they cross boundaries. They go in all directions. The cords are usually fixed, the framework is involved, and the larynx is dysfunctional. So this will give you an understanding of how you will classify your patients, and this actually helps you plan the treatment for your patients going ahead. So an early laryngeal cancer subjectively will have normal laryngeal function. No aspiration, the airway is clear, the patient may have hoarseness or odynophagia. Objectively, you'll find that both the cords are mobile and the framework is intact. And usually these do not manifest with any neck nodes unless they are supraglottic cancers. When you look at the advanced cancers, subjectively, the patient will have a compromised laryngeal function. Patient may be aspirating, having a blocked airway, have hoarseness or no speech. Objectively, you will see that there's cartilage widening. There's a loss of the cricoid crackle when there's a posterior extension. There's gross exolaryngeal spread and may not have multiple or bilateral nodes. So larynx is actually very unique because of its location, the embryology, and it makes an important consideration when you're assessing your patient and towards decision making. When you look at larynx, there are 2 main subsites, the supraglottis and glottis. The third is subglottis, which is below the level of the vocal cords. The supraglottis consists of epiglottis, aryepiglottic folds, arytenoids, and the false cords, while the glottis consists of true cords, the anterior and the posterior commissure. Now, why it is important? Because embryologically, they have derived from different enlarges. What it means is that they would have a separate blood supply, innervation, and lymphatic drainage pattern. So supraglottis comes from arches 3 and 4, and the glottis and subglottis come from arches 5 and 6. This also creates certain barriers of spread. So there are compartments within the larynx which will not allow the tumor to spread and prevent its invasion of the surrounding structures. So these compartments, once you understand them, will allow you to do some form of conservation so that the disease can be resected completely and oncologically. So you have these compartments such as the supraglottis, the paraglottic space, the Rinke space, and the barriers are the thyroid cartilage, the quadrangular membrane, the ventricular ligaments, and so on and so forth. The spaces are very important. Moment they cross the vocal cord or the cartilage, they will be in a space which is beyond the mucosa and the cartilage or the muscle. And these patients then have what we call characterized as a T3 or intermediate or advanced cancers. So you might have a lesion in the vocal cord which spreads beyond the muscle into the paraglottic space, and then it is free to go in all directions so that your ability to contain them reduces. So in early glottic cancers, these are usually indolent diseases because this area has less vascularity and has sparse lymphatics. And this allows us to have narrow margins of 1 to 2 millimeters. In the subglottis, in the supraglottis, and the hypopharynx, you would have to traditionally stick to the 5 millimeter margins. Now, when you have a lesion in the midcord, you're worried about the lesion either spreading into the muscle or the paraglottis. So when you have a lesion like this, you know for sure that there is no ventricular involvement or a paraglottic space involvement. But when you have a lesion like this, where your false cord seems to be full, you know that this patient may have a possibility of a paraglottic space involvement. Anterior commissure lesions are likewise very vicious. There is no barrier beyond the vocal cords, and the tumor can spread from the anterior commissure and involve the cartilage early on. So whenever you have lesions in the anterior commissure, you need to look at how these tumors are spreading, and it is incumbent on us to do proper imaging to rule the anterior commissure and cartilage involvement. Tumors such as coming on to the supraglottis tend to spread into the ventricle and come on to the cartilage or the preepiglottic space. The moment you have got lesions which are going above, you again need to evaluate carefully the preepiglottic and the paraglottic spaces. Tumors which are having a subglottic spread tend to now come onto the cricoid. Cricoid, as you know, is the rostrum of the airway. If you remove the cricoid, the airway will collapse. So if you have lesions which are now having a subglottic spread, and you look at this diagram, which nicely shows you that if the lesion is less than 10 millimeters at the anterior commissure, it will not involve the cricoid. If it is less than 5 millimeters posteriorly, it will not come onto cricoid. So this will explain to you which of these cases, when you evaluate, will tell you the possibility of offering conservation surgery to your patient. Now, when the disease goes into the paraglottic spaces, as I said, it allows for the free spread of the disease. So your patients can have either a subglottic spread, and then it can go via the cricothyroid membrane into the exolaryngeal space. So when you have a subglottic disease or you have a disease coming posteriorly onto the arytenoid, you need to look out for an exolaryngeal spread. Now, what are the patterns of lymphatic spread? In the glottis, they are very low intensity spread. As I explained, they have very sparse lymphatics. So in T1, T2, you have less than 5% involvement of occult disease in the lymph nodes. Even in T3, T4, they'll be less than 20%. And which levels are involved? Usually levels 2, 3, and 4. And if you have a subglottic spread or a cricothyroid escape, you would want to consider looking at the level 6, that is the paratracheal lymph nodes. In the supraglottis, the diseases spread along the level of the hyoid, either above it or below it. So this is the free border of the epiglottis. So if you have a lesion which is along the free border of the epiglottis, coming on the A fold, these are the marginal zone cancers. They are more common and they are proliferative. And also the marginal zone cancers in the suprahyoid supraglottis will have lesser intensity or for a lymph node spread. The ones that, however, are infrahyoid supraglottis are deeply infiltrating, and through the natural canaliculi in the cartilage, they will early on involve the preepiglottic space. Literature also shows that involvement of the preepiglottic space has a higher risk of nodal metastasis. Now, when you look at the patterns of spread in supraglottis, they have a very high incidence of occult metastasis. So in contrast to the glottis, which has less than 20% in T3, T4, here in T1 cancers as well, you might have up to 40% incidence of occult mets. and they involve levels 2, 3, and 4 as well. Now, when you look at the patient with the tumor, you need to evaluate clinically if the cords are mobile or not. Is there laryngeal widening? What is the neck extensibility? Sometimes the tumors go into the post-cricoid space, into the prevertebral space, and you might not have a possibility of an extension, which suggests that the tumor is more extensive than what it appears. You need to document the nodes as well as its location. And finally, you need to document what is the voice quality. Imaging plays an important role in the staging, and assessing the laryngeal framework and anatomy is critical today for having a proper decision making. So you need to characterize, as I mentioned before, whether the disease is involving the paraglottis, whether the disease is involving the preepiglottic space, and you need to characterize whether the thyroid or the cricoid cartilage is involved. So when you're looking at a lesion today, all your patients should get a CT scan apart from the very small mid-cord lesion on the vocal cord. The CT scan and MRI upstages your clinical staging in 90% of patients. So you need to corroborate your clinical findings with the CT scan. When it comes to the cartilage invasion, the CT scan is preferred over MRI, and the specificity is better with a CT scan. But when it comes to the inner perichondrium, you will want to take the help of the MRI, because it will tell you with better specificity about the involvement of the perichondrium. When you look at the PET scan, the sensitivity and specificity is not as good as a CT MRI. So you would prefer to still do a CT scan first in all your patients. And if you have problem solving to be done, you will go to an MRI. Direct laryngoscopy today was the gold standard to evaluate, but today you can do the similar evaluation with a flexible laryngoscope. You also have a possibility of a bronchoscope, which has got the ability to do insufflation in order to see the piriform and the postcricoid. Nevertheless, what do you document with a laryngoscopy? You document the size, you document the sites involved, you want to know the superior and the inferior extent, and you want to know the involvement of the endolarynx. Finally, you want to know whether you will require reconstruction, and for that, you want to know the extent of spread across midline. Those of you who are evaluating for conservation surgery, you need to do evaluation with a suspension laryngoscope, because then you will be able to identify where is the tumor in location in relation to the postcricoid, that is a cricoid cartilage, and the cricoidnoid unit. Remember, for conservation surgery, the minimum that you need is a cricoid, intact cricoid, and one functional recurrent laryngeal line. Now, this is the staging that we follow for TNM. What is important to know that any cord fixation is a T3 lesion. And in stage grouping, a T3 lesion involves a T1, T2, N1, and a T3, N0. Apart from all this, today your evaluation is not complete without functional assessment. So you need to use certain instruments such as the China swallowing scale, which evaluates the quality of life, the penetration aspiration scale, which evaluates what is the functionality of the larynx protection, the airway protection by the larynx. So anything that is PAS score 2 and above is very good functionality. PAS 3 to 5, there is compromised function, and PAS 6 and above, the patient is severely compromised. So today, if you want to assess the patient in order to choose a organ preservation protocol, you will want to use the penetration aspiration scale. The next is the dysphagia scoring. You need to use the dysphagia scoring in order to understand what is the patient's functionality as far as the swallowing is concerned. And finally, you have all the criteria that you require. What is the general condition of the patient? What is the composite of a clinical and radiological findings? Is the laryngeal framework intact? Is it involving the pre and paraglottic spaces? And is there an exolaryngeal spread? You will also have the laryngeal functional status as well as the staging. And together with all these findings, you can do a joint clinic evaluation and treatment decision making for your patient. So in short, when we are focusing on T1, T2, you're concerned with voice preservation. When you come to T2 and T3s, you're concerned with organ preservation. And when you look at T3s and T4s, you're more concerned with cure. So there are certain factors that affect your treatment decisions, the tumor factors, patient factors, and the physician factors. And I feel that the physician and treatment center factors are most important because all of us are competent enough to identify the tumor and patient factors, to understand what is your technical expertise, what kind of equipment you have and your expertise in them, and that should guide you towards planning an effective treatment for your patient. So in short, in early laryngeal cancer, the treatment options are a transoral resection, radiation therapy, and open partial laryngectomy. In intermediate laryngeal cancers, you may have combined transoral laser surgery with neck dissection or open partial laryngectomy. And now we can offer these patients concurrent chemoradiation. And in advanced laryngeal cancers, you may either do a near total or a total laryngectomy along with neck dissection. Thank you very much for the patient listening.
Thank you so much, sir. Moving on to our next speaker, Dr. Subbiah sir requires no introduction. We have always been inspired by his carefully curated videos and edited videos that we get on IASO academic group. And he also posts some quiz for us to answer. So today we decided to have him on this platform to spread some of his great work with all of us. So I will start your video, sir. Just one moment, I'll put myself on mute.
Subramanian is always an inspiration for us. And Sharad Desai is there, my friend and senior. And Toprani sir. Many people are there. Probably I have not done any big work in comparison to the other panelists here. Anyhow, I will try to share my little experience, whatever I have in surgical oncology field. Am I clearly audible, Ziva?
Absolutely clearly audible, sir. I'll put myself on mute and share your video again. I'll start from the top.
Narendra is my neighbor in Tirupati.
Yes, sir. Subbiah, sir.
Yes.
You
can. I will restrict my thing with the video length. That is roughly around 15 minutes. I'm not able to see the video being shared.
Is it?
Is it shared? I don't think so.
No, it's not seen. I think it came now.
I think now you are able to see.
Yes.
Yeah.
It started.
Thank you. Here I present a case which is T3N0 involving the left glottis with a huge involvement of paraglottic space. And such lesions, she underwent already tracheostomy. And such lesions, I little venture into organ preservation. Since there is a pre-existing tracheostomy done outside an institution which is not having expertise in managing laryngeal cancers, we need to adjust with the already pre-existing tracheostomy in our incision selection and tracheostomy fashioning. This patient, I preferred an apron flap from the level of mastoid tip on the anterior aspect of sternum of one side to other side. And since it's a bulky lesion, I chose to do level 2, 3, 4 dissection also, a 5 dissection also. Anyhow, Venkatesh will be sharing his ideas extensively on neck dissection. So I may not trouble you by much on neck dissection. But anyhow, in this patient, without showing neck dissection, I cannot proceed because it's a locally advanced disease, in my opinion. Even though the cartilages is not involved, the paraclatic space is hugely involved, particularly on left side. And usually here the level 5 lymph node dissection is being shared at the postero-inferior angle of the neck. That is where we usually start our dissection, identify the omohyoid, post-inferior belly, go above. You should be careful to preserve the accessory nerve. Probably in these videos, now I have not come to the accessory level. Later on I will show you. And I am clearing the fascia over the sternomastoid so that it goes to the posterior aspect of sternomastoid. The retraction is on the posterior inferior angle. The upper one, the lower one is on the sternomastoid. And level 2, 3, 4, and few nodes I sent for frozen also. The level 2 node that came as negative. So I used to use both cautery and scissors both. Any fine dissection on a critical area, I prefer scissors rather than cautery. And the level 2 nodes, since the 2 node was which was removed was not positive, I didn't aggressively dissect the level 2B node so that I can preserve some function. It's a level 4 node that is being removed and sent for frozen section. Unfortunately, we don't have frozen section, so we send it for imprint cytology, and our study showed that almost 80% of time we can correlate with imprint cytology itself. And here again, I am standing on the right side. The cameraman will shift right to left. So not frequently. Here, since the lesion was predominantly on left side, I removed the left lobe of thyroid while preserving the right lobe of thyroid. In my opinion, preservation of thyroid is to preserve the parathyroid there rather than thyroid function. My worry is on the parathyroid injury rather than the thyroid function, which can be easily, any derangement can be easily managed. So this is in my finger is internal jugular vein. And probably I'm going posterior to the thyroid gland on left side because I didn't bother to preserve the thyroid gland on left side. So I didn't identify. This is the rectal laryngeal nerve that is being exposed. Since I was very sure about operability, it is without seeing the plane between trachea and so esophagus, I divided the nerve. Now I switch to right side. Right level 2, 3 lymph nodes also removed. Here also another. Probably these nodes may be because of infection associated with this previous in tracheostomy. I don't know. I don't remember exactly because it was 1 year old, and I think all the nodes were negative. That is why in the introduction thing, it has been noted as T3N0 by my resident. And most of the quality of video curating, everything should go to my resident, and it's my job is only to operate and see that it is videographed properly, and the work is predominantly done by my resident, and the credit should go to them, not to me. Probably the only thing I did was encouraging them. Here I preserved the right thyroid gland. I said already my purpose of preservation of right thyroid lobe is to preserve parathyroid predominantly. And by the way, sometimes if I'm not irradiating, the thyroid function also may be preserved. But most of the cases, we used to do thyroid function test post-operatively and manage the patient accordingly. None of our patients had so far tetany in the post-operative period. Here I am introducing my finger. Many may not accept. I am introducing finger between the esophagus and trachea. Here I have started dividing the suprahyoid muscles. At least the central part of hyoid and epiglottis should be included in any laryngectomy because you need to remove the in toto to remove the pre-epiglottic space. Mylohyoid, geniohyoid, hyoglossus, stylohyoid, all are removed. When you are going to the greater of hyoid bone, you should be careful because it is closely related to lingual artery, branches of superior thyroid artery, and hypoglossal nerve. Hypoglossal nerve is one thing you should be bothered to preserve at this place. Here, that is left superior thyroid artery. Since I am going to remove the lobe, I divided it. Superior artery on left side is divided. Right side, I have not seen the superior artery because I wanted to preserve the superior right lobe of thyroid. Just I divided the laryngeal branch of superior artery. Here on left side, I am proceeding. You'll be able to see the carotid, and it is again in the suprahyoid area near the greater horn of hyoid bone on the left side. I remain close to the hyoid bone just to avoid the structures, vital structures. In anatomy, there is one of the short notes is structures around the greater horn of hyoid bone. I still remember because I was fortunate to be a tutor in anatomy after my MS, and that refined my anatomical skill. Here, we have to purchase more mucosa and varicula. I remain close to the epiglottis. Mucosal purchase is one important component of any laryngectomy in the vallicula and in the piriform fossa if both are not involved. If both are involved, we cannot do. So preoperative assessment, as Prathamesh pointed out, it should be done very thoroughly. And we enter the epipharynx, see the inside, then divide. If you're going to divide blindly, then you may end up in cutting through the tumor. Here I have gone through the tip of epiglottis. First, I am dividing on the left side so that inadvertently I am not cutting through the tumor. Left side, I was little liberal in cutting the mucosa away because the tumor was predominantly on left side. Whatever mucosal purchase I wanted to do, I did more on the right side than the left side in this patient because here left card, including commissure and left paraglottic space were involved. You can see the Ryle tube inserted. That's an important aspect of laryngectomy because you need to feed the patient through Ryle tube unless you are not going to do percutaneous endoscopy gastroscopy. Right pharyngeal constrictors are being removed. Again, whatever mucosal purchase I could do, I did it. And coming down, already right and left laryngeal nerve were divided. Another point is you should not skeletonize the thyroid cartilage because to give soft tissue clearance, adjacent thyrohyoid and sternohyoid muscles should be removed along with whatever superior homohyoid comes near. I am dividing here under vision that the trachea so that I am not entering. And I am refashioning the trachea. When I cut trachea, I take care that it is obliquely cut with more amount of posterior wall of trachea so that I will have a proper tracheostomy. Here, even though I had a little option because already tracheostomy was done, I used the part of tracheostomy pre-existing, the inferior aspect. I didn't disturb that. Only the lateral superior aspect I refashioned. One thing we are really bothered about in any laryngectomy, and we keep our fingers crossed, is fistula after. I don't know, the others should tell me what is their fistula rate. If I include very minimal leak rates, because most of our patients are post-radiation. Sometimes it goes up to, I don't remember exactly, but I think it is 40%. If you include minimal leak, major leaks are very less. The loss of life was not noticed, but we have done salvage for major fistulas in quite few number of patients, like maybe around 10 patients. And trimming the pharyngeal mucosa, hoping that I will not leave or I will not suture together the deviate-laced pharyngeal mucosa, but I don't know. These things will help or not, I don't know. The seniors here, including Subramanieshwar, who is jack of all trade, and others should comment. And I close here in a T-shaped manner. If it is a very early disease, you can, and mucosal purchase is good, then the entire thing may be vertical or transverse, depends on. I started in inferior aspect. I am closing the mucosa just above the esophagus, beginning of esophagus. So the one thing you should take care is the mucosa should be inverted. It is easily said than done, particularly in post-RT scenarios. And in this patient, since the constrictors were, it is upfront surgery, not post-radiation, and the soft tissues were virgin without getting irradiated, I had the luxury of closing the suture line with closure of constrictor muscles. If you see the 9 o'clock position, the retractor should steadily retract the chin. That's very important. And it should be in the midline always. Otherwise, your videography may not be good. In doing videography, the assistants are more important than the surgeon. The surgeon should bother about his head not coming in between the room camera and the field. I used to tell my residents, every surgery you do, you assume that it is being watched by hundreds of people and you are operating in a workshop, and that is how you can be meticulous in every surgery to improve your skills. I used to think like that. And I'm happy to operate where it is being watched by many, because that will make me more cautious, stick to principles more often, and improve my surgical skills. We had a good setup in our institution, including room camera, laying it to the auditorium. And the major work, as I said already, is done by my residents. I should thank them profusely always. I cannot forget any demonstration of my videos. I can't afford to forget my residents every resident used to edit at least one video a week. All the surgeries are photographed, including the laparoscopic surgeries. Unfortunately, we don't have robotics. This is the before closure of the horizontal aspect. You can pause here for some time if you want. And you can see suprahyoid muscles, ligated superior artery, right side, on the left side, right side, I'm not able to see because I didn't go to that place. Pharynx, reconstructed interjugular vein, common carotid left side, left interjugular vein. Okay, you can proceed. You can, now the tracheostomy is fashioned. As I told you, pre-existing tracheostomy limited my maneuver around that area. Stoma, I used to go complete the show stoma first because I want to leave the closure of other component to my residents. Usually I take the stoma fashioning and the pharyngeal closure is done by the senior-most person because that leads to problem always. I never leave the stoma fashioning to my residents unless I have good confidence in them and they have assisted me in quite few cases because many a time the stoma complications are bothering us more. And platysma is closed and after the skin is being closed. And you can see I used this is after closure. One drain was two drains, and this is a specimen. You can pause here. You can see the epiglottis, tip of the epiglottis is seen. I had bone, okay. Left side, the tumor is more, if you see. And the thyroid lobe on left side is seen in the specimen. You can move ahead. I think it's over. Yeah, thank you. Thank you for good opportunity. It's a privilege to be a part of first such series. And I profusely thank the organizers in general and Professor Subramanian in particular. Thank you.
Thank you so much, sir, for that insightful video. We'll reserve the questions for the end. Now, moving on to our next presenter. May I welcome Dr. Venkatesh Vaidilingam from Chennai Adyar Hospital. Sir will be covering a video tutorial on neck dissection. I think you have, you are going to present the video from your end. Yeah.
Good evening, distinguished guests and audience. Am I audible?
You're audible.
Is the video visible?
Yes, sir, absolutely. I think you can make it full screen. Is this full screen?
Yes, this is full screen.
Okay.
I think it's okay. It's okay.
Okay, sir.
So, I'm Dr. Venkatesh, a surgical oncologist from Cancer Institute Adyar. This is a very common surgery which is done in the surgical oncology fraternity. I often say my residents that the thing which differentiates a general surgeon from a cancer surgeon is two. One is giving adequate margins during the resection of the primary, and the second is lymphadenectomy. So we have neck dissection, axillary dissection, inguinal block dissection, retroperitoneal lymph node dissection. So let us concentrate today on neck dissection, which is a very common surgery being performed. So this is a patient who had a retromylotrigon cancer. This video was shot in 2014, and this neck dissection is a part of the composite resection done for retromylotrigon cancer T4A N1M0. The patient is in supine position with shoulder pads under the shoulders, with neck extension, head tilted towards the opposite side, the parts painted and draped. So certain landmarks after draping should be visible before the surgery is started. One is the angle of the mouth, the midline mandible, the midline of the neck, the medial end of the clavicle, the entire clavicle and lateral end of the clavicle, the ear lobule and the mastoid tip. We see the anterior border of sternomastoid, the external jugular vein, the ear lobule also here. So this is an incision, it's a curvilinear incision starting midline from the vertically down in the submental region and horizontally midway between the lower border of mandible and the clavicle, and a vertical extension is being given. This incision is not being performed nowadays. This was done in 2014, and nowadays if you are doing a standalone neck dissection, only a transverse skin crease incision is performed. So one of the important points during placement of incision is the skin gets its blood supply from the platysma. So the blood supply of platysma should be clearly known to all the residents. Superiorly, the platysma gets its blood supply from the facial branches of facial artery and occipital artery. Inferiorly, it gets its blood supply from the branches of the transverse cervical artery. The incision, the wounds is scored for proper approximation of the scar after the end of the surgery. The next important point is this: when you make an incision on the marked line, the incision is deepened up to the platysma. What I'm meaning by that is that when you use a cautery to cut the skin, the incision should be deepened up to the platysma because that area of the skin will derive its blood supply from the platysma alone. Another point which is important is that whenever you are planning a trifurcation, 3-point junction, it should be placed adequately posterior to the internal carotid artery. This is the line of the internal carotid artery. So, well posterior to the internal carotid artery, the 3-point junction should be placed so that even if the wound breaks down, it will not be over the carotid artery. The another point of interest is while putting a vertical down incision, it should be at right angles to the transverse incision so that the tip of the incision does not undergo necrosis. The skin incision is deepened, subcutaneous plate is divided. The inferior skin incision is placed. So this is where we give traction and counter traction in any surgery. The skin hooks are used to raise the upper skin flap. The tooth forceps is used to retract the lower skin flap, and a traction and counter traction is being given. The classical subplatysmal skin flaps are being raised. If you see, as we go in the midline, in the mental region, and as you go posteriorly in the postauricular region, the skin flaps will not have platysma underneath. That is, the platysma will be deficient there. So, when raising a skin flap there, one should be very careful not to put a buttonhole in the skin flaps. This is the region I am talking about. This is the greater auricular nerve, and this is the external jugular vein. The skin flaps are sutured to the drapes. The inferior skin incision is deepened up to the platysma, and the antero-inferior skin flap is being raised. We are doing this neck dissection as a part of composite resection. The medial end of this skin flap raising should not go up to the midline because when you perform a tracheostomy, the drains will not hold there. So the lower flap is completely raised. While raising the posterior flap, one should be very careful about the presence of spinal accessory nerve, which very superficial in the superficial plane, just deep to the skin. And here also the platysma is deficient or absent. So as textbooks give, there are 4 cornerstones of neck dissection. One is the midline mental region. The other is the mastoid tip. The lower end, the middle end of the clavicle, and the other one is the lateral end of the clavicle. So this is the consternations of neck dissection. Now you can start your neck dissection from above downwards or below upwards. Here we are starting from below upwards. We divide the lower end of the sternomastoid. And create a plane between the sternomastoid and the strap muscles. So the fascia over the internal jugular vein is being dissected. And the fascia over the internal jugular vein from below upwards is being incised. Here we now see the omohyoid muscle. So all the important structures in the neck are above the superficial to level of omohyoid. The vascular structures are below the level of omohyoid. Now we are going to the level 1A dissection. 2 important points should be noted while doing 1A dissection. One is that the 1A here also the platysma is deficient. So while raising skin flaps, you should not make a buttonhole in the skin. The second point is this level 1A area is not covered in the bilateral opposing radiation field. So it is the primary duty of the surgeon to give adequate clearance of the level 1A nodes. So after adequate clearance, both anterior belly of digastric should be seen. Next comes level 1B dissection, where we will be preserving the marginal mandibular nerve. So everybody knows that your incision should be 2 to 3 centimeter below the level of the mandible. The marginal mandibular nerve lies in between the fascia, investing layer of deep fascia and the submandibular gland. So if you go in this plane, open your artery, divide the investing layer of deep fascia with bipolar and divide with scissors, your marginal mandibular nerve will be seen. Now, how to preserve it? You have to identify it. How to avoid injury to it? Don't use cautery, trace the entire nerve and use bipolar, and by ligate it away from the nerve. So we are using bipolar and dividing the deep fascia. We are not using cautery. And here is the common facial vein. Facial vein. If the nodes are big or if there are large perifacial nodes, then we might have to sacrifice the marginal mandibular nerve. Here we see the marginal mandibular nerve and the facial artery and vein. We ligate it, put the clamps well away from the marginal mandibular nerve. These are the ways to preserve the marginal mandibular nerve. Now use a cautery to divide the fibrofatty tissue in the level 1B region. Now after removing the superficial lobe of the submandibular gland, we will see the mylohyoid muscle here. So this is when we retract the mylohyoid with a small thumb retractor, we will see important structures there, which is very important for the residents. One is the sympathetic ganglion given by the lingual nerve to the submandibular gland. This is the V-shaped lingual nerve, the ganglion given to the submandibular gland. That we bipolarize it and divide. Next is the hypoglossal nerve, which is being dissected. So in between the lingual nerve above and the hypoglossal nerve below will be the submandibular duct. We divide the duct with a cautery. This is one of the constant anatomy, it does not vary. Now we divide the common facial vein. And then ligate it, divide it. Then we see the facial artery arising from the external carotid artery. We double ligate it. So that completes level 1A and 1B dissection. This is the step which is very important because this is the entry of the external jugular vein near the tail of the parotid. While doing a classical radical neck dissection, the tail of the parotid nodes are also resected and divided. One of the important things while doing this thing is that it often bleeds. So it is better to do running sutures over the tail of parotid. The resident's anatomical knowledge is very important here. One of the important muscles which helps a resident to identify the nerves are the posterior belly of digastric, which helps us to identify the internal jugular vein and the spinal axillary nerve. Here we are dividing the superior end of the sternocleidomastoid. Now we are dissecting the fascia over the internal jugular vein. The level 2B tissues are also being dissected. These are all the level 2B tissues. The fibrofatty tissue or the level 2A is being separated from the internal jugular vein. Here we clearly see the internal jugular vein. You should not use cautery here because sometimes in elderly individuals, the carotid knuckle will be very curved, and if you use a cautery over that, you can injure the carotid artery. So this is one of the steps I want to enforce for the PGs. That is, when we are doing a level 4 dissection, you don't use cautery, you use ligate, clamp, and divide. This is the steps you have to do because of the possible injury to the branches of the chyle duct, especially on the left side. You don't go looking for the chyle duct, you just divide the fibrofatty tissue above the level of transverse cervical artery without looking for the chyle duct. If you see it and if there is an injury, you repair it with a 4-0 prolene. These are the tissues in the level 5 region. Now, this is the ascending branch of the transverse cervical artery. You might have to clip it. Using a cautery, we are dissecting the level 3 tissues from the internal jugular vein. This is the ventral primary rami of the C2, C3, C4 nerves. These ventral primary rami supply the skin, sensory supply over the skin above the clavicle. This is a level 5 tissue being dissected. The inferior belly of omohyoid being divided. So that completes the level 5 dissection. Now, phrenic nerve and brachial plexus are two important structures which are often not usually seen. If you are able to preserve the prevertebral fascia, if your plane of dissection is above the level of the prevertebral fascia, superficial to the level of prevertebral fascia, you will never injure the phrenic nerve and the brachial plexus. So phrenic nerve is the only nerve which comes from lateral to medial when compared to all other nerves which come from medial to lateral. One another important anatomical point is now we are seeing the dissection of the level 2A and 2B tissues. This is where we are going to see the spinal laxity. So this point, I will stop the video. This point where the spinal laxity is seen running down over the internal jugular vein. If you palpate underneath with your finger, there will be the transverse process of the second cervical vertebra. This is very constant. So if you are not able to find the spinal laxity at its exit from the skull base, you palpate the transverse process cervical vertebra. 9 out of 10 times you will find the spinal laxity over the internal jugular vein. So here we see a rare anomaly, seen in 15% of the patients where the spinal laxity goes posterior to the internal jugular vein. Majority of the patients, spinal laxity goes anterior to the internal jugular vein. So avoid using excessive cautery over the spinal laxity. So we are tracing the spinal laxity nerve from along its entire extent from top to bottom, dividing the fibers of the sternocleidomastoid and also dividing the branches of the spinal laxity to the sternocleidomastoid. This is one of the methods to identify the spinal laxity. The other method is the Erb's point coming from below upwards, which is Erb's point is nothing but 1 centimeter above the level of the greater auricular nerve where the spinal laxity exits. So we are tracing the spinal laxity. It dips downwards midway between the upper border of the mandible and the lower border and the clavicle. And when it reaches the trapezius muscle, it lies almost superficial. One another point while dissecting the spinal laxity is do not completely denude the entire fascia of the spinal laxity. Let it the deeper portion lie on the prevertebral muscles, thereby preserving the blood supply to the spinal laxity. Here we see the carotid bulb in this patient, curved carotid bulb. C2, C3, C4 ventral primary rami. So we give Valsalva. This is very important to check for two things, chyle leak and hemostasis. If there is any chyle leak, use a 3-0 or 4-0 prolene to ligate the injury in the chyle duct. So these are the structures at the end of the procedure, and two anterior belly of digastric, myloid muscle. Myloid muscle is retracted. The hypoglossal nerve, the V-shaped lingual nerve here, hypoglossal nerve, the transcervical artery, the phrenic nerve, the vagus nerve. This is one important point, anatomical. But this is the splenius capitis muscle, and this is the levator scapulae muscle. Sometimes, if you are doing a large nodal mass, which is where we have to remove the adventitia of the carotid artery, then we have to cover the carotid with a levator scapulae muscle flap, which can be divided. Levator scapulae gets inserted into the clavicle, and by dividing its insertion of the levator scapulae from the clavicle, you can bring it up and cover the carotid. The scalenus anticus and posticus muscle. The fibrofatty tissues are separated and given in pathology department as separate specimens. The wound is closed over a negative suction drain. I thank the IASO team, Dr. T.S. Rao sir, Dr. Sharad Desai sir, Dr. Rudra Acharya for giving me an opportunity to present our work. Thank you. Now also at this point, want to invite all colleagues to all the postgraduate for a model exam being conducted by Cancer Institute on January 4th and 5th of 2025 in the new year, which is for all exam going postgraduates, and all second years and first year also come. It's a medal exam that IASO is also giving a prestigious medal for all the best performing presenters. Thank you, everyone.
Thank you so much, sir, for the very detailed and clear video. Yeah. Can you please stop sharing? Yeah. Thank you again, sir. I will not hold any of you back. I know all of you all are getting anxious to go and celebrate with your families. Just a quick announcement for abstracts, for oral poster and video presentations for the Puri MidCon. It will be held from 8th to 10th of February. You may submit your abstracts. Please scan the QR code quickly. Now, very quickly, we will proceed to some few questions that we have managed to jot down. If the experts can quickly just answer them. So I think we've answered the first question. The rima glottis and the glottic chink are the same. And another question was, how would you address a flap necrosis post-laryngectomy? Any precautions that you would take during the surgery or after the surgery? Subbiah, sir?
Meticulous surgery, that's all.
Okay, sir. You are in a hurry.
No, I'm not in a hurry, but that's the truth, you know. You should be meticulous about anatomy, you should be meticulous about dissection, and you should be meticulous about vascularity.
Right, sir. Right, sir. Any alternate incisions for neck dissection, sir? You've shown the Y-shaped incision. Any alternate, especially for modified radical neck dissection?
Modified Schobinger is the commonest incision used for composite resection if you are putting a PMC. But if you are putting a free flap, a single transverse incision should be more than enough. You need not remove the sternocleidomastoid also. But
Right.
if you want to do a segmental mandibulectomy, you have to put either a lip split or an angle split.
Right, sir.
I think, Reba, in a laryngectomy, you will need to do today a possibility of a horizontal incision. So an incision placed just below the level of the cricoid allows you 2 centimeters of space for fashioning a stoma, which is separate. A separate incision and a separate stoma is advisable for a glottic cancer. If you have a pyriform sinus cancer, you might want to do a glux, for instance, in order to get approach to the neck, as Venkatesh said, in order to get the sternomastoid for a flap inside. But all in all, a horizontal incision serves better. There is a lesser drag on the stoma. It is separate from the site of leak if it occurs. And all in all, the healing of the stoma is much better.
Right, sir.
Can I add something?
Absolutely, sir.
So I agree with what our Pratmesh has told. Any neck surgery can be done with a properly placed transverse key increase incision. Any extent of neck dissection can be done with a transverse, and it gives a very good cosmetic result also.
Right. Thank you, sir. I think sir has covered on the specific precautions that we must take to avoid injury to the lymphatics. However, if it still occurs, the post-operative guy leak, how do you handle it? How do you tackle it, sir? Venkatesh, sir. May I unmute yourself, sir?
If you see a Kyle leak after the end of the neck dissection after a Valsalva, then it is better to do the closure of the leak with a 40 or 50 proline on table itself. Sometimes what occurs is that you have to take adjacent tissue because Kyle is a fragile, it does not have adventitia or tunica. So if you do a silk stitcher or tie over it, it will cut through. So you have to take adjacent fascia along with the injured Kyle duct so that it holds thing. One other thing is whenever you see a Kyle leak, for example, on the first post-operative day, on table you are not able to see it, but on the first post-operative day you see it, immediately if it is high output fistula, more than 200 ml, immediately go ahead and explore and suture the leak rather than waiting for 5 days when the tissues become fragile and going again and doing it is very terrible. So whenever you notice a high output fistula, please go ahead, immediately open the neck. Sir, anything you want to add, Pratmesh, sir?
No, I agree with you that Kyle leak has to be tackled immediately if it is a high volume output, because in our analysis that we did, the average stay increases, almost doubles if you're going to use octreotide and wait and watch. So you should go and tackle that. And as you said rightly, you need to bury the Kyle duct at the site where it has been punctured. If you look at the Kyle leak anatomy, it comes from behind the carotid and then enters to drain into the internal jugular vein with the external jugular vein junction. So you need to take the stitches at that point so that it can compress the entire Kyle. At times you might use silk. At times you might want to use your regular white krill. But whatever you do, see to that it is compressed between the carotid sheath as well as the prevertebral.
Did you have to use thoracoscopy as an adjunct to control the Kyle leak when you fail in the neck?
Absolutely.
Pratmesh, Venkatesh?
I think we have had cases where we have had to do a lot of medial to the carotid dissection for large nodes going into the mediastinum. And at that time, you might have injury to the Kyle before it goes behind the carotid. And those are very difficult to control. And is like Venkatesh said, it might manifest a day or two later with very high output drainage. Those are sometimes where you may not be able to achieve any seal medial to the carotid. And the thoracoscopic ligation is clipping. It just takes a few clips in order to just close it. And today there are intervention techniques where lymphangiographic methods are used to just occlude the entire thoracic duct. But I still feel that thoracoscopic ligation is fast, quick, and serves the purpose.
I too did recently too. I have a very short video on that also. It's really good actually. It immediately brings down the leak. And I took a lot of tips from Subramanian also.
Thank you, sir. So much, sir. Yeah.
So we conclude today's short meeting. I invite Dr. T.S. Rao sir to give a few words on this session.
We have been incubating about this session on mastery of surgery because there are so many youngsters coming into the market. There are so many residency training positions across the country. So they should not only be taught the the science of oncology, but the art of oncology also needs to be taught on a continuous basis. So this has been discussed by the past presidents and secretary and the current president, Dr. Sharad Desai was very keen that we get going in this year itself. So we've chosen this day, the last day of this year, so that it will be an inspiration for us throughout next year. So we thought we should do head and neck, to start with head and neck, and Prathamesh was the only one that we thought about to talk about the first talk on correlation of endoscopic anatomy, histology, and radiological anatomy of the larynx, both morbid anatomy and the normal anatomy. Well, wonderful talk, Prathamesh. It would set the ball rolling so that wonderful, great work happens on the IASO mastery of surgery. I think we have opened the innings very well. We have had Subhaya Shanmugam, senior professor, very passionate surgeon. He's very passionate about much more skills than anything else. So he takes all the pain to continuously post and then take feedback, stimulating young people in the ISO academic group and in his own institute. He's been an inspiration. Venkatesh doing great work in the institute. It's not easy to be in these institutes these days. You all need to be very passionate, compassionate to continue to do such good work. So we also wanted Venkatesh to show neck dissection because he's very dedicated to head and neck work. I think we really enjoyed this short session. I think we'll extend this in the next year to about 1.5 hours. We didn't want it more than 1 hour, and I think it has been a very crisp, clear, wonderful session. I really enjoyed it. Thank you very much, Prathamesh, Subhaya, Shanmugam, and Venkatesh.
Sir, thank you, sir. Thank you, sir. Thank you.
Thank you, sir.
Thank
you
Council,
very much.
yeah, I appreciate the efforts, consistent efforts of Sajan Shukla and Ziba Yusufi. Without them, I would be nowhere. Sharad and Rudra, you have been a source of great support and energy for the master class and now the mastery of surgery. Thank you very much for the unstinted support. We hope to not to disappoint you in the next of whole year. We'll be very inclusive, and we request younger people to send videos. We'll give some guidelines. We'll ask the younger people to edit videos and post them. We'll put it to a selection board. We'll be unbiased. The selection board will have each organ system will have real experts, the seniors in the community. Select them, and then we have them on this session. So this is only to expand the faculty base to multiple layers of consultants, not just the senior most, but various other consultants who speak to residents. So wonderful days ahead in the new year. Happy New Year, all of you. Thank you very much.
Thank you, sir. Yeah.
Happy New Year, everybody, and thank you very much. It was a great learning experience for me too. Thank you.
Thank you, sir. I just invite our ISO Secretary, Dr. Rudra Acharya, sir, to wrap the session with a vote of thanks. Rudra, sir.
Yeah, I think this was one of the best sessions because we wanted 360-degree coverage of an organ system. So this mastery of surgery was planned because you see only discussing the cases and the theoretical aspect, then not applying mind to the surgical aspect and the pitfalls, the techniques. I think this became very well formatted and coming up well for the first session, that is the head and neck one. And I think subsequently we will cover all the organs. I thank the speakers for the first ISO Mastery of Surgery, Dr. Prathamesh, Dr. Venkatesh, and Dr. Subhaya sir. I think and ISO Indo-American team for doing this coordination so well. And in future, we will be more oriented to youngsters, and all students can take the advantage. Thank you very much. Happy New Year. Welcome to MidCon Puri. All of you must attend and send the abstracts and set the ball roll for a great MidCon at the sea beach at Puri. Thank you very much.
And Pradmesh, you were anxious about the crowd. At one point, there were 139 on the Zoom and about 50 on the 49 on the YouTube. So close to 200. It has never reached this number actually.
Sir, it's all because of you.
Not really. Because of the faculty. Great job. Thank you so much. Happy New
Thank
Year.
you, sir.
God bless. God
Thank
bless.
you much. Thank you
Bye,
very much.
everybody.
Thank you.
Bye,
Thank you
sir.
very much.
Bye. Great
Thank you.
session. Thank you.
Thank you.
Thank you, sir.